expect to get some pressure lowering, expect to get medication reduction, but not to the degree of trabeculectomy. Now, there is more evidence in MIGS that we see that when we do MIGS procedure, especially with cataract surgery, there's an improvement in pressure control. There's less visual field progression, less surgery that's needed. And it's very similar to what we see with SLT. Even though medications and SLT are similar, the success rate is higher and less progression and less need for more surgery. Same thing with trabeculectomy. Same thing with MIGS procedures. Sorry, there is less need for medications. There is less progression, less need for more surgery. So MIGS fits in kind of this middle ground of pressure lowering, where our targets are usually mid-teens. When we want to go lower, we have to go subconj. And phaco, of course, also can lower pressure to a modest amount. Now, trabecular meshwork procedures, we know that they're safe, but the debate always is they're effective enough? The safety part comes from the fact that we will not get hypotony because we have the episcleral venous resistance that prevents hypotony from occurring. On the other hand, we cannot get very low pressure because of the episcleral venous resistance. And we know with any procedure, there's a lot of important pearls that are important to think about, and we'll mention some of these as well. Now, what's the ideal patient for MIGS? For me, the ideal patient is combining with phaco because they work well together. Unlike phaco-trab or phaco-bleb procedures, where there's a bit of antagonism between the two, right? There's more inflammation that can cause the trabeculectomy to fail. Trabeculectomy long recovery, phaco short recovery. Phaco MIGS works well together. So I like the idea of combining it when you're doing cataract surgery. In fact, for me, anybody with glaucoma going to cataract surgery, they usually get a glaucoma procedure. Usually MIGS, but sometimes we do MIBS or bleb surgery as well. As a standalone option, we do like it in younger patients because we feel that it has a better effect, just like we see in congenital glaucoma. But even patients who are 40, 50 years old, uveitic glaucoma as well respond well. And older patients who have mild to moderate disease. Where we find it doesn't work as well in our hands is patients who have much more advanced disease and older patients who have very heavy medication load and have advanced disease. Those patients have a lot of problems in their eyes and their trabecular meshwork outflow system is quite diseased. Remember, when we do mixed procedures, we talk about overcoming resistance at different levels. There's trabecular meshwork, there's the canal of Schlemm, and there's a distal outflow system that we have to address. If the distal outflow system is not functional, then even if we can remove trabecular meshwork, the pressure may not lower enough. So understanding outflow, which goes from the anterior chamber, trabecular meshwork, collector channels, aqueous veins, and where they are important. These veins are important. These veins are about 3 to 4 in every eye, and they are more commonly present inferiorly. This is where most of the larger aqueous veins are. So if we're going to do a procedure that is segmental or partial, it makes sense to do the procedure infranasally, whether it's stenting or whether it's cutting or using KDB or a partial GAT. Because aqueous outflow is pretty well segmental. It goes through trabecular meshwork. So we want to do the opening in the area where there's going to be more potential for flow, less resistance. As we learn MIGS, the first most important thing for MIGS is visualization and positioning. This is critical, and that means we have to be very comfortable with intraoperative gonioscopy. Not everybody is, but it's important to learn the different approaches. And we typically use a gonio prism. We want to get the best view, cleanest view, but it's important we do not compress the cornea while we press on the eye with the device, which is very common. It's also important we tilt the microscope to be able to look into the angle using a prism. Tilted at least 40, 45 degrees, like we see in the picture here, because this will give us the best view into the angle with the gonio prism. The patient's head is tilted as well, about 30 degrees away from us, and this gives us the best angle. So learning MIGS setup is very important. Visualization, we can't see how important it is. This becomes the most important aspect of performing MIGS procedures. And so take the time to set it up right. Now, when we're doing MIGS with cataract surgery, the question comes, do you do the procedure before the phacoemulsification or right after? There's some benefits to either approach. I like to do it before the phaco. Why? Because we have the best view, the firmest eye, less blood reflux. But some people like to do it after. I think you do what you're comfortable with, but that's my approach. The other thing is sometimes if you have an eye with very light pigmentation, then using trypan blue can be helpful to stain the trabecular meshwork, as you see here, beautifully stained, even though the pigmentation is very light. And so it helps us to view, and here we see the eye stent being placed. Now, one of the problems we see with any MIGS procedures at the beginning when you're learning, this will be what happens when you learn, is we have a poor view. You know, we have bubbles into the anterior chamber, a lot of corneal stria. You can see we cannot see properly. Blood is coming on the surface of the eye. Blood is coming into the anterior chamber. So we have to take the time to set it up right. You can see that we have a bit of a top-down approach, which we'll talk about. And so this is typical. Look at the stria on the cornea because we're pushing on the eye, pushing on the incision. This is what's going to happen to you when you start doing MIGS. But like anything else, take the time to do the setup right. Practice this before doing the procedure, even in regular eyes, by getting a good view. You know, here's an example where we have, you know, a MIGS procedure here, but you can see that there's bleeding on the surface of the eye, and this really hampers the view. It really affects the view. So be careful. I do like to make limbal incisions, but I'll be careful to avoid blood vessels on the cornea when I make my incision. Otherwise, we're fighting with blood on the cornea. The other pearl I want to mention is top down versus en face. Top down means we're looking down into the angle rather than straight ahead. This happens because the eye is not turned enough or the microscope isn't tilted enough. So tilt the microscope, turn the patient's head to get a proper en face view. It means a view head on. Here's an example where we start the case. The surgeon doesn't have a good view. It's top down. We're looking into the iris rather than onto the TM. We cannot see properly the structures of the angle and the planes to work in. Now we rotate the eye a little bit away from us, rotate the eye, and we can see the trabecular meshwork much more easily visualized because of that approach. A couple other pros I'm going to mention is parallax. So when we're looking at trabecular meshwork, remember which way we're looking at it. We're not looking at the TM directly like this. Because when we make a corneal incision and place a probe or something in there, we're coming at it from the top. A steep approach. Remember this approach. If this is the canal of stem, this is trabecular meshwork, if the approach comes in and is too far back, you'll miss the canal. This is the middle of the TM, but because of the angle we're approaching, we're going to end up posterior. So instead, aim at the top of the TM. The top of the pigmented TM will allow us to get into the canal rather than getting in supraciliary space. So aim, again, high enough, because remember the view we have is different than what you think about when you're looking at the angle straight on. And so where would you want to place the probe or the knife or the stent or the eye or whatever? We want to go on the higher side toward the border between the pigmented and non-pigmented TM. I think that's the most important pearl in managing this. I think what I'm going to pause here, Lala, if you don't mind, I'm just going to, I have many slides, of course, here, but I want to pause and maybe take some questions and have some discussion here, because I think that might be more interesting than hearing me talk. But I wanted to give, a little bit of a background on MIGS, some pearls on MIGS, the different options on MIGS. I mean, there's a lot of different options we have in front of us now. So I hope there's some questions.
So
I see some more faces now. I see.
Yeah.
Some of you are still hiding. Why are you hiding? Okay, Turkan came. Parveen didn't show up. She still has her face picture.
By the way, she lives in Boston. Maybe she's at work right now, and that's
Why are you working it now already? Come on. That's fine. Good excuse. Thanks for listening, though. Norana's been paying attention. Wow, no reaction from her.
Nurana.
Mehmet, look at Mehmet. Mehmet is happy.
Yeah, seems like perfect.
So yeah, I mean,
Yes,
please,
questions,
please, if there's any,
discussions. Yeah.
I'd love to get some questions.
Yeah, yeah,
Dr.
yeah.
Ahmed, thank you, Ahmed. Thank you for the great presentation. And you share with us tips in microinvasive glaucoma surgery. Thank you for that. And most of the doctors who want to start to do this procedure, they want to know when Dr. Aik Ahmed decided not to do MIGS. I mean, you talk about the stage of the glaucoma is mild or moderate. I mean about the level of the IOP with medication or without medications, phakic or pseudo-phakic patient, regarding the long-term using the medication, and also if the patient had the diabetic retinopathy. Of course, not neovascular glaucoma.
Yeah, no, I agree. Not with neovascular glaucoma. So my first, so this is always a good question when I make a decision. My first point of the fork in the road is whether they're doing cataract surgery or not. If you're doing cataract surgery, then I go one way. I'm already doing surgery. So why would I not do something for the glaucoma if you have glaucoma? You know, and I'm talking about open angle glaucoma. Of course, you know, different other conditions may be different. Angle closure, we have experience with, but those are off label. I do use it as well. But let's talk about open angle glaucoma. I would like to combine something with the glaucoma procedure. Then I look at the severity of disease. If the severity of disease is very advanced, then I may shift toward doing a bleb if the pressure is not controlled, because I don't think MIGS will be enough. That's where I would say MIGS won't be enough. On the other hand, if they have mild to moderate glaucoma, even if the pressure is high, I will try phaco MIGS because they have a chance of getting success without a bleb. Because the bleb is a very big, procedure long term. So that's the cataract side of things. Without cataracts, it's a bit trickier because you have to go to surgery just for the procedure here. So in this case, I do it a couple scenarios. Again, advanced disease, patients progressing, maximum meds. I'm typically going to a bleb. I feel they need to have a bleb. I do a lot of bleb surgery. I do trabeculectomy. I do Zen. I do PreserFlow. I do a lot of those surgeries because those patients need it. MIGS is not enough for that. But if the patient's mild to moderate, maybe their pressures are high. They're on 2, 3 medications. I would definitely do MIGS in that scenario. If they are even controlled but they're not compliant or they're not tolerating medications, I would do a MIGS procedure. So those are the kind of categorizations that I use in terms of whether to do it. Cataract surgery, it's a no-brainer. I do it a lot, except when the patient has progressive advanced disease, despite their pressures being normal. Those patients need to have a pressure of 8. We can't get it with MIGS, or less than 10. Otherwise, cataract surgery with MIGS, I'll do it a lot. Standalone, I do them more for patients mild to moderate, uncontrolled disease, and on medical therapy, or controlled disease, but poorly compliant, or a lot of side effects. Of course, they've already have SLT. SLT, I've assumed they've already had, because in my practice, SLT is always what we do first line. We'll do it before MIGS. But that's generally how we think about it as far as doing MIGS procedures. So, it's a lot of surgery we do now because we have all these options available to us.
Okay.
But curious what you think.
Dr. Imran, do you have the comments or questions?
Well, first of all, thank you for your tip.